very lucky to have Rachel Cooper here today. She's the McArdle Chair at Aging and a professor of epidemiology at Newcastle University, UK. She was visiting the US earlier for GSA, the Aging meeting last week, and she wanted to stop by San Francisco on her way back home. So we're really happy that she could be here. She's been in meetings with us for the last couple of days, and she's here to share some information about sarcopenia, multimorbidity, etc. She's going to present from the front. We'll change the slides from the back. If there's questions, do you want people to wait to the end or interrupt you?
If there are points of clarification.
Okay, clarification in the meantime, otherwise bigger points, wait to the end, and we'll monitor the chat in Zoom in case any questions come up then.
Great,
thanks. Thanks, Rachel.
All right, thanks. And thanks, Peggy, and thanks for everyone for coming. So it's a real pleasure to be here and to have the opportunity really to reflect on kind of the work that I've been doing and the parallels with the work that you do here in the centre. So yeah, please bear with me. So can I have the next slide, please? Sorry, Tom, there's been a lot of this. So I just wanted to put this up here because I don't know if Peggy remembers, but my first kind of exposure to Peggy and her work was back in kind of the early 2000s, where I was undertaking a systematic review and meta-analysis and wanted to include individual level data from lots of different studies. So I just sent out as a postdoc emails to lots of different investigators, some of whom didn't reply, others of whom gladly provided the data. One of those people was Peggy. So this is from a paper that came out of that work. So Peggy's name was kind of attributed in that. And then if we can have the next slide, please. Just to fast forward to now, and there was a really great opportunity towards the end of the back end of last year and into this year to work with Peggy again on this big review piece for Nature Reviews Disease Primer on sarcopenia. So there's kind of lots of shared research interest, and it's just really nice to kind of get the opportunity to be here and to kind of discuss some of the work that you're doing and understand those parallels a little bit more. The next slide, please. So because I've come from kind of UK, I thought it might just be helpful to kind of position myself and so you can understand my journey around the country. So I come from a place on the coast in the northwest of England where the Red Star is up on the kind of top left-hand side, and the relevance of that is it's one of the most deprived areas in the country in terms of like seaside towns, coastal problems with health. So if you look at kind of health indicators, life expectancy, healthy life expectancy, Blackpool, which is just down the road from where I grew up, has some of the worst kind of results there. And so that has kind of probably inspired me throughout my kind of work, thinking about inequalities in health, which I'll come back to later. I then went and did my first degree in Oxford, so that's the kind of orange part there, in a degree in human sciences, and then moved to London, which I didn't think needed kind of its own start. London, and where I did a master's in epidemiology and a PhD in life course epidemiology. And I was based there then for the next 10 to 15 years working on different studies that I'll refer to today. More recently, after a stint working in the Department of Health and Social Care in the UK government in London, I moved up to Manchester and came back to academia with an academic post at Manchester Metropolitan University. So Manchester is where I currently live, and that's the picture down on the left-hand side. But I spend my working life in Newcastle, so that's shown on the right-hand side here. So that's kind of down by the River Tyne, and the kind of oldest building in the university. Not all the university buildings look like that one, but that's the only all the brochures. And so kind of based out of Newcastle for my work. So next slide, please. So I'm based in the AIDS Research Group in the Translational and Clinical Research Institute in the Faculty of Medical Sciences at Newcastle University. And the vision in our group is to improve life through world-class research in ageing, sarcopenia, and multiple long-term conditions, what you'd call multimorbidity. And so we're an interdisciplinary group, so clinical geriatrics, epidemiology, data science, sport and exercise science. And we do lots of close collaborative working with the NIHR Newcastle Biomedical Research Centre, thinking about patients and members of the public. With a clear focus on team science, it's really nice to be here and see how you all operate here as well, and the translation of research findings into advances in the prevention, diagnosis and treatment, with maximum benefit for individuals and society. So next slide, please. So this is just a quick view of our group. So I co-lead this group now with Abhinay Sayer, who's a geriatrician, who then you will have seen her papers, and also an epidemiologist. Miles Whittam, who's a professor of trials in older people, and a range of other kind of people with varying expertise. So a really great group that I work with there in Newcastle. So next slide, please. So then my specific research aims, and these have kind of evolved over time, but have remained pretty similar for probably the last 10 to 15 years, are around applying a life course epidemiological approach to the study of aging, sarcopenia, and multimorbidity, really with the aim of identifying those opportunities right across life to maximise people's chances of living healthier, independent lives for longer, and with a clear focus on reducing inequalities in those chances. And more recently, my focus has pivoted towards thinking about how best we work across disciplines to enable effective translation of that epidemiological evidence into patient and public benefit. I could probably quite happily sit and write papers on an epidemiological kind of focus for the rest of my working life, but it's thinking about those challenges and those opportunities to really make sure that that work is kind of having a difference in the way that you would hope. So just to say a little bit about life course epidemiology, so if I could just have the next slide, please. So I had the privilege of working for many years with Diana Koo, who's now retired, and Yoav Ben Shlomo out of Bristol, who were the first to coin the term life course epidemiology, which is, as the definition outlines here, the study of the biological, behavioural and psychosocial pathways that link a whole range of different exposures right across life to influence adult health, function and disease risk. So that came about because of the concerns. There was kind of two schools of thought in the UK back in the 1990s. There were the people that were still pursuing kind of a clear focus on the adult lifestyle models of disease. And then alongside that had come David Barker and the fetal origins of adult disease hypothesis. And so those two kind of factions were kind of competing with each other. And this was an opportunity to try and bring those two schools of thought together and recognise that really we need to be thinking about things right across life. It's not early life just by itself, and it's not just adult lifestyle models, which seems really obvious, but as I say, they were really opposed and quite kind of difficult conversations happening in the field of epidemiology in the UK, but with recognition that life course thinking was seen across other disciplines already. So this wasn't a completely new idea, but it was bringing it back to the fore. So given one of the motivators for kind of this rise in life course epidemiology in the UK in the 1990s was fetal origins of adult disease, I thought it was helpful, if I can just have the next slide, go back one, yeah. So I acknowledge the work of Avanai Say, who I've already mentioned, who I work quite closely with now in Newcastle, and her work, which was some of the first to suggest that we should be thinking about a life course approach to ageing. So really just to acknowledge her early insights into this field moving forward. So if I can have the next, please. So working with Yoav and Di, I was involved in some work just to really assess life course epidemiology in the early 2000s, once it had been kind of a term that had been used for the last 20 years, and think about its relevance for research on ageing. So this is just a plot showing number of publications, year of publication, and then number of papers using the term life course in either their title or abstract. So you can see this massive upsurge in a number of papers throughout the 2000s that are kind of making reference to life course thinking. Quite often that was just in a concluding statement where it's like we need to do more and think about this across the life course, but there's been a definite shift towards kind of a widening thought on this and moving from firstly a specific focus on diseases like cardiovascular disease to more broad thinking about a life course approach to different aspects of health outcomes. So that's where the book Life Course Approach to Healthy Aging, shown on the right, came out of that work. So if I could have the next slide, please. And then just given this audience, I thought it'd be useful to show that that's seen whichever disease area or kind of set of conditions you look at. So this is taking papers using the term life course in a title and abstract. And then also one of the following terms, so musculoskeletal sarcopenia, osteoporosis, etc., which was a kind of updated version of the search I showed you on the previous slide. So again, number of publications, year of publication, and you can see this kind of upsurge in the number of papers where a life course approach has been taken to the sorts of outcomes that I'm interested in kind of musculoskeletal function and health. So next slide, please. So the benefits of applying a life course approach, I would argue, it encourages consideration of the timing, duration, and temporal ordering of different exposures. And it also forces us to consider quite explicitly characteristics of anyone's specific exposure and how that might change over time, thinking about age at onset, duration, and change with age, with the aim of providing etiological insights into lifelong processes that influence aging and health, and generating evidence on the type, timing, and targeting of most effective interventions at different life stages to promote healthy aging, with a growing recognition that opportunities to effectively intervene are missed if we don't start studying aging until 65 plus. And I know I'm speaking to an audience that completely understand that, but just to put this in context, maybe about 10 years ago, I had a kind of back and forth with the editor of JAGS, because they wouldn't even review our paper because our study participants were aged 60 to 64. And so that wasn't, even though it was an aging phenotype, they weren't interested because they weren't 65. So I think it's important. I think we're moving away from that, but it's still important. So then what I'm now going to do is just do a summary of some of the work that I've done that's relevant to sarcopenia. So if I can have the next slide, please. But when I was thinking about this, it's really interesting because now I can round most of the work that I've done over the last 10, 15 years and kind of demonstrate its relevance to sarcopenia, but that wasn't really my primary motivation. So when I first moved into thinking about kind of the sorts of things that I've been working on now for 10 to 15 years, my primary focus was really physical capability, which is shown on the left-hand side. So that's the ability to undertake physical tasks of daily living, and thinking about the different ways that we could characterize that, its value as a measure of healthy aging, and how we could think about how that changes over life and the influence that has, all with a focus on what those important clinical outcomes are that relates to, that if we can modify these measures, can we impact and kind of benefit the clinical outcomes. But the clinical outcomes wasn't the starting point for the work that I did. But ultimately, a lot of what I have done does speak to kind of better understanding, I think, the life course epidemiology of sarcopenia. So I've kind of done it backwards in a way. So if I can have the next slide, please. So if we think of sarcopenia from a life course perspective, it's the accelerated loss of skeletal muscle mass and function. And we have along the bottom a time scale from birth to death. In most people, sarcopenia, if we're thinking about that, that's primary sarcopenia, so age-related, it's not going to be manifest until people towards the end of their life. So if I can have the next slide, please. So then is physical capability, so by which I mean there's performance measures and things you'll know well. There's an opportunity potentially to study relevant variation prior to the clinical manifestation, as well as important impact of sarcopenia. And the next slide, please. And that's all within the context of thinking of aging as a lifelong process. And then just, sorry, one more Tom on this. So and then that kind of encourages us to think about the opportunities for intervention across life, and the kind of need to think about the both prevention and treatment. Again, it's nothing you are all thinking about anyway. So then I can have the next slide, please. So the ways that I've gone about my work in this area, thinking about it, is to exploit special features of specific cohorts for in-depth analyses, and I'll say more about those studies in a moment. Cross-cohort research, so thinking about harmonizing data across studies, consistent analysis, and then the kind of additional work that allows you to do investigating confounding variables. And then systematic review and where possible meta-analysis of all available studies, taking back to the first paper I showed, where I'm just trying to do that to look at mortality as an outcome. So if I can have the next slide, please. So I just wanted to say a little bit, I know I almost feel like a little bit of fraud speaking to this group, because I know you have a wealth of amazing data resources here in the US that you kind of run out of the centre here. But I just wanted to highlight the UK's portfolio of population-based studies. So we do have, I think we can say, a world-renowned portfolio of population-based cohort studies. And the Medical Research Council, which is the equivalent of NIH, I guess, did a review back in 2014, so 10 years ago now, that identified 34 cohorts ranging in size from 150 to 1.24 million, and more studies have been initiated since. So 3.5% of the UK population are currently taking part in cohort studies, with the age range spanning the whole life course from birth to over 100 years old, all collecting a range of different measures, anthropometric, lifestyle, socioeconomic measures, most also collecting physical health data, and some with linkage to routine data, so kind of electronic health records. And that includes a number of studies with assessment of phenotypes relevant to the study of sarcopenia at different life stages, some with repeat measurements and some with repeat measurements of potential risk factors, allowing for the study of cumulative effects and detection of sensitive fields. So we can have the next slide. And so for about 15 years, I had the privilege of working on one of the kind of unique studies in the UK, which is the top one here. So in the UK, we have these 4 nationally representative British birth cohort studies. So these are all studies that have recruited people born in 1 week of a specific year, 1946, 1958, 1970, 2000, and have then followed those people up over time prospectively. So I worked on the MRC National Survey of Health and Development, which recruited 5,362 people at birth, and follow those people up, still following those people up over time now. So I was involved in the data collections for that study when those participants were 60 to 64 and 68 to 69. And it's data from these types of studies that have allowed me to do quite a lot of the work that I'm now going to present. So next slide, please. So just thinking about key life course questions, and these are questions that we can apply in different settings, and that I apply to sarcopenia here. So sorry, there's more animation than, so next slide, please. So the first question that we can now ask here is, can we identify phenotypes that capture meaningful variation at different life stages? So if I can have the next slide, please. So the first example here is taken from the BMJ paper that I showed you right at the beginning of the talk. So are measures of strength and physical performance associated with important outcomes? So we did some work back when I was a postdoc, taking evidence from systematic reviews and meta-analysis to highlight that lower levels of physical capability, so by that I mean grip strength, walking speed, chair rise in this case, are related to lower survival rates, and that's what's shown in the plot on the right-hand side, where the numbers relate to the number of studies, not the number of participants, and you can see these clear patterns of association with poorer performance and higher rates of mortality that other people have also shown. Earlier onset of disease and disability, and lower levels of positive mental well-being. And also importantly, evidence from qualitative studies showing that physical decline is perceived by older people as an important challenge of aging. So if I can have the next slide, please. So then we'd shown that in a systematic review that there were these associations between the variability in these physical performance tests and mortality, and that was consistently found across different studies, but the majority of those studies were in later life. And so we were keen to use data from the 1946 study to interrogate whether the observed variation in these physical capability tests at age 53 years was also associated with all-cause mortality. So that's what's shown here. And what you can see is that meaningful variation is observed at younger ages, and so those people who are unable to do the tests have much poorer prospects in terms of their mortality, but there's also grading where those people in the lowest fifth of performance are also doing worse than the rest. So evidence that if we measure these things earlier in life, before people have reached old age, is still telling us something about people's prospects for future life. And next slide, please. So then I had a PhD student, Lizzie Block, who was interested in the self-reported measures and this idea of a hierarchy of functional loss, which I'm sure many of you are familiar with. So kind of start seeing people reporting difficulties with different tasks in a specific order. So first people start reporting difficulty cutting their toenails, and so it works up to the point where they were reporting difficulties getting out of bed, dressing, toileting, that sort of thing. So it kind of follows this typical hierarchy. So these are data just showing the prevalence of reporting difficulty with gripping, walking, climbing stairs in men and women at ages 43 through to 60 to 64. And what jumps out is the kind of massive increase in the proportion of people reporting difficulty even at 60 to 64. But of the 12% of participants reporting difficulty gripping, walking and or stair climbing at age 43, those participants were 3 times more likely to be reporting difficulty feeding, washing and or toileting themselves at age 60 to 64 years. So these are relatively young, relatively healthy people participating in a population-based study, and we're still seeing these major kind of differences over time. So I think it speaks to the fact that we are seeing kind of meaningful variation at younger ages, and hence that kind of call to think about aging earlier, which I think we're now seeing. So if I can have the next slide, please. So then kind of a second set of life course questions is around how do those 5 phenotypes that we're seeing that seem to be showing meaningful variation at different life stages, how do they change across life, and what do we understand about those? Are there also period and cohort effects and socio-demographic differences? And can we identify any specific periods of life when important changes are observed? But we can have the next slide, please. So this is some work we did trying to harmonise data on physical performance and strength across 8 British studies to look at individual differences. So, so we've managed to harmonise the data. And so here you can see kind of, well, you can't see that clearly, but kind of patterns as you'd expect in kind of declining performance with increasing age and the gender differences that you'd expect. I purposely didn't put these figures into these kind of numbers into a figure because I was worried that people would infer age-related change from kind of cross-sectional data. But I think actually I made a mistake, because if we go on to the next slide, that's what Richard does. A very dear and sadly missed colleague who sadly passed away a couple of years ago. He did this work where we pulled data from on grip strength from 12 different birth cohort studies. And so we've got data right across life, and then he was able to put these growth curves across those. And these have gone on to be used to kind of identify cut points for sarcopenia in the European Working Group definition. So these are still in many cases cross-sectional data, but he was able to kind of show and demonstrate the value of those in a way that I was cautious of doing, because I didn't want to infer intra-individual differences from my inter-individual differences. So it's interesting. So this has definitely been a more powerful output and more important and impactful. So next slide, please. So in the 1946 cohort, we did get 3 repeat measures over time. And so that then allowed us to model grip strength trajectories between ages 53 and 60 to 69. So you've got this for males on the left and females on the right, different scaling of the women's weaker strength. And so what you can see is these 3 different kind of latent classes of changes in grip strength over time. And we looked at that in relation to a range of different factors, and very little was explaining the slope, which is what I think people typically find. And it was all about the kind of explanation of the difference at baseline, which speaks to needing to think about kind of life course effects. So that's our attempt to look at intra-individual differences in grip strength, which shows that we're doing that. And final example for this question is just about thinking about birth cohort differences. So next slide, please. Is thinking about birth cohort differences in grip strength. And we'd had hoped in that initial analysis I showed you, where we were looking across 8 studies to look at birth cohort differences. But what we found is that if people have data at the same age, that was probably because they were born at a similar time, because the age range of our data collection period was too narrow. So working with a colleague, Heine Strand, who was one of the National Institute on Aging Fellows that worked with Jack Lalnick for a while, we were able to use Norwegian data for Tromsø study. And so what you've got here is men on the left, women on the right. The solid black line is those people that were born in 1931 to 1949, and the dotted line is those people born in 1910 to 1929. So what you can see here is that you've got that same pattern of age-related difference. So again, these are cross-sectional data. And so age-related differences in grip strength in both the cohorts, but kind of shift upwards over time. So the people born in the more recent born cohort are stronger than those born in the kind of earlier cohort, which could be partly attributed in this cohort to the higher educational levels and greater height. But again, those things are both things that are set in motion in earlier life and spoke to this need to take a life course perspective to how we think about who ends up weak and with poor function once they get to later life. So, sorry, next slide. So then a key part of the work that I did for quite a long time was about what are the factors potentially modifiable across life associated with relevant phenotypes at different stages of the life course. So next slide, please. So I'm not going to go into the details of all these, but just really to kind of acknowledge the fact that we've identified and studied a range of potentially modifiable factors associated with either the development, maintenance, and or the timing and onset and rate of decline in relevant aging phenotypes. So key ones for me, and I could talk at length and give a whole presentation, for example, on obesity. Done quite a lot of work. I have real concerns about what awaits us as more people reach old age, having lived more of their lives obese. And I don't think we've fully understood the implications of that yet. So I've done quite a lot of work where I can to interrogate the potential implications of that using different cohort data as well, because we do have really good serial measures of BMI from childhood onwards. Lifetime health behaviours and socioeconomic circumstances. I'll say more about socioeconomic position on the next slide, but also quite a lot of work around the cumulative effects of physical activity and thinking about whether kind of we can look at census periods and things like that using the data that we have available to us. And then thinking about the interactions of cognitive capability across life. My PhD was on a women's health outcome, so I still have this interest in reproductive health and type and time in menopause and thinking about those. I think we too easily assume that any changes that happen to women in their kind of late 40s, early 50s, and differences that emerge between men and women, we can attribute to that. And I think we need to do much more to better understand the data available to us. So next slide, please. So, I mean, it's easy to say that it's kind of creates work for oneself, but I think what's come out of the data is that many of these life course associations are complex, as you might expect. So there's a move in the UK, I don't know to what extent it's happened here, to thinking about using Mendelian randomization analyses. The danger there is, even if it's possible, is that you're assuming a lifetime effect of an exposure variable. A lot of our work speaks to the fact that these things don't have a constant effect over time. It's just cumulative in that way. And so I think there's still value in thinking about how we use those types of approaches and complement them with the analyses that we can do, taking advantage of the fact we have these resources at different ages and different cohorts. So I've ordered these I usually order them by publication date. When I was looking at these papers last night, actually the story is easier to tell if I order them by age. So one of the most recent papers I did with a PhD student out of Manchester was using data from the 1970 British cohort study, so born in the 1970s. And so they, at age 46 years, had their physical capability assessed and had grip strength measured. And when we looked at cumulative effects of socioeconomic position, so we have childhood measures as well as adult measures, we find that lower socioeconomic position across life is associated with grip strength in women at age 46 years. But what emerged in men was really quite interesting, in that lower socioeconomic position in adulthood, and here we were using occupational class, which seems important, was actually associated with stronger grip strength. So some of those people in the lower end of the socioeconomic position actually had the strongest grip strength. And that was largely explained by the higher level of occupational activity in skilled manual occupational groups. When we get to 53 years and we look at the data from the 1946 cohort, so born kind of 24 years earlier in the MRC National Survey of Health and Development, we've been able to do more there because we've got serial measures lost time. So at age 53 years, there's been no association found between socioeconomic position and grip strength. At 60 to 64 years, modest association between lower socioeconomic position and weaker grip strength had emerged. And then changes, DICU looked at changes between 53 and 69 years in grip strength and found that lower childhood S&P was associated with faster declines in women, but there was no association in men. And so I think there's something quite interesting happening with the men in these studies, probably related to their occupational activity and what happens when those people retire. And what it also points to is the fact that there are age and sex-specific interventions probably required to reduce socioeconomic inequalities and sarcopenia risk. And I think there's a key question, at least in the UK, where this is kind of coming through in all the data that we look at. We've also looked at it in the UK Biobank and find something similar about how we can kind of help men, or what needs to be done to help so that men of lower socioeconomic position maintain any midlife strength advantage that they appear to have then into later life. So next slide, please. So in all of this work, it's thinking about what the relevance of that is and how translatable is it and what value does it have. So we have had some kind of impact in terms of some of the work that I presented in mortality analysis was cited in the UK Physical Activity Guidelines. Richard's beautiful plots and informs the cut points for weakness in the Sarcopenia guidelines out of Europe. And we have been involved in some work on panels of biomarkers. But if I can have the next slide, please. So I think it is fair to say that in the last 2 decades, major progress has been made towards improving our understanding of the life course epidemiology of many age-related health conditions, including sarcopenia. And epidemiological analyses utilising a wealth of data sources, including those in the UK, have contributed to this. And so while the value of the life course approach to ageing and health is now widely recognised and often referred to in international and national policies, it's often at a kind of quite tokenistic level of we need to take a life course approach, or it means that they've studied some children and they've studied some older people, but not necessarily joined up any of the dots between them. So it's really unclear whether it has resulted in maximum patient and public benefit. And so I think about that quite a lot, and how do we address this and achieve more effective translation? So if I can have the next slide, please. So I'm not suggesting this is a model for everyone, it's just me thinking about my role as a life course epidemiologist and the kind of things that I do and the opportunities that I'm taking to expand the portfolio of things that I get involved with a key towards moving towards translation. So really interesting to hear what's happening here in the centre and all the work that happens in the translational space and thinking about the geroscience approach. Because more and more through work in the Age Research Group in Newcastle, working with people who have expertise in biology, physiology, really with a key to identifying kind of novel targets for interventions at an individual level. And we're doing that in part through our study, the Mass Life Course study, which similarly to SOMA, but on a much smaller scale, is recruiting people and kind of doing deep phenotyping with their muscle phenotype, mainly muscle biopsies and other kind of measures. So that's one side of things. But then on the other side, I'm inspired by my time spent in government, working in the Department of Health and Social Care, thinking about those opportunities to influence with the data that we have public policy. So working with people who are on the ground delivering public health interventions, working with public health teams and local authorities to identify the levers for change at a community and societal level. So this is just an example of a report I've been involved in recently, showing stark regional inequalities in women's health. So in the UK, in England, we have major north-south divide in health prospects. And so women up in the northeast, where Newcastle University is based, have a average healthy life expectancy of just 59, which compares to 66 in the southwest of the country. So there's these stark differences in quite a small country in people's prospects. So even just shining a spotlight on those differences and presenting them as they were at the Houses of Parliament gives us an opportunity to highlight the fact that we need to be doing more and doing better. So next slide, please. So next steps, thinking quite carefully about how we bring together people from different disciplines and facilitate join up of ageing research around the translational circle. And you present the perfect model of kind of how we should be doing that in the UK, I think. So and I'm thinking about where were the opportunities for a population level approach and or epidemiological findings to directly inform work in other disciplines and vice versa. And where should we be really thinking about integrating research across disciplines to transform our understanding, and rather than saying, oh, it's too difficult to do that, actually pushing forward and trying to break down some of those barriers to achieve that. And what partnerships we need to develop and maintain. So we're contributing to this in a minor way in the UK through the Art of Healthy Ageing Network. So the Biological Research Council sent out, have funded 11 networks whose sole purpose is to bring people together from different disciplines to think about ageing across the life course. So it's all about kind of bringing people together and thinking about how we learn each other's languages and begin working in a more collaborative way across disciplines. And I think we're further behind on that than what I observe in the US. I think we need to think about how we enhance population-based studies and other types of data resource, such as electronic health records, and undertake international comparisons, and think much more creatively, take opportunities to draw on expertise from a range of different disciplines to develop novel measures and resources that address important unanswered questions. And I know you're doing exceptional work in this space here. And then this is my segue into just saying a little bit about multimorbidity. Apply a life course approach to improve our understanding of other important age-related health outcomes. So in the last few minutes, I'm just going to briefly, so in the last 4 years, I've spent more of my time thinking about multimorbidity alongside the work I've presented today. So I'm just going to kind of go through that quite quickly to give you a flavour of it, and if it's of interest, do just reach out. So next slide, please. So multimorbidity has become a massive focus of research endeavour in the UK, I'd say, in the last 5 years. So since the publication of the Academy of Medical Science report shown here on the right in 2018, there have been several major funding initiatives on multimorbidity in the UK. So pretty much every major research group that does health in the UK has got at least one project ongoing on multimorbidity. And so we've had we have Mission Research Collaborative, which has funded for 4 years and comes to an end next year, which aims to transform understanding of multimorbidity in people admitted to hospital, where there was a real gap in most of the work that was happening in primary care research and population-based studies. And healthcare in hospitals in the UK, at least, is very much focused around treating single diseases. So it's not fit for purpose within multiple. And so kind of trying to better understand the patient populations using electronic health records, using population-based studies to interrogate some of those kind of associations we were observing in the electronic health record data a bit more, and then also undertake one-to-one interviews. So it's kind of been across this piece and kind of mixed methods and multi types of data. So really interesting project to be involved in. So next slide, please. Really with a view to addressing this challenge. So the chief medical officer in the UK, really influential, has a priority setting in terms of kind of research funding and things like that. He put out a report last year, which is of his choice, Professor Clissrity. It's of his choice what it focuses on. So it was really kind of helpful for those of us working in the ageing research community in the UK that he chose to focus on health in an ageing society. And so what you've got on the right-hand side is the front cover of this brochure. So this is just showing projections of the percentage of the population aged 75 years and over. And what you can see is kind of, as it gets darker, the higher percentage of people over 75 in 2021 projected for 2043. And so you can see that the areas that we work up in the northeast are going to have a higher proportion of older people. Some of the kind of where a lot of the research maybe goes down in that southeast corner. And kind of just reflected in that is this plot is taken from that report on the left-hand side, but just showing the kind of massive increase in prevalence of multimorbidity with age, but also the patterning of socioeconomic patterning of multiple long-term conditions, especially at younger ages. So something there which probably I think is driving the reductions we're now seeing in healthy life expectancy, especially in kind of regions that have been hard hit by kind of austerity measures and things like that. So next slide, please. So I'm kind of now, as part of my portfolio of work, thinking about how we apply a life course approach to address the stark inequalities and multimorbidity that we see. So this is an infographic that is effectively kind of translating for a public audience the data shown on the left-hand side, which is again just showing along the bottom age, along the y-axis you've got the percentage of patients with multimorbidity, so some primary care data, and then you've got the lines by tenths of socioeconomic status. So the red line is those people in the most deprived neighbourhoods, and the black line is those in the least deprived neighbourhoods. And what you see is that there's a massive gap, 10 to 15 years of the age at first developing multiple people with different levels of exposure to deprivation. And next slide, please. And we can link that back to the other things that we're interested in the age-related space. So I'm not going to say too much about these, just really to acknowledge that within our group, we're thinking not about these things in silos, but about the interrelationships between the work we do on sarcopenia and the work that we're doing. So I won't say any more about those, but just kind of flag the work that we're doing at the interface between the two things I've spoken about today. And next slide, please. And just to say, it's been a privilege to work with Anne Newman, who many of you know from Pittsburgh, recently for there's a new version of the life course approach to chronic disease epidemiology, a book that IQ co-edited, the first one off in the 90s. So was invited to work with on a chapter on a life course approach to multimorbidity and healthy eating. So that'll be coming out in 2025. So I think there's a lot more to do there, and the work that we identified suggested kind of lots of areas where we can take things forward in the future. So before I wrap up, if I can just have the next slide, please. So I just wanted to end by saying what a privilege it's been to be here, and how much I do appreciate the opportunity to kind of come and hear what other people are up to meet with you all. You've all been very generous with your time. And to think about the opportunities and kind of things it exposes you to. So you get lots of opportunities kind of for new experiences. So thank you, Peggy. It was nice to get to try Waymo last night. I probably wouldn't have otherwise. But it's also kind of food for thought. And I know some people in the room aren't choosing to engage with the news at the moment, but I got back to my hotel room last night and engaged with the news, and I just thought I had to put these in here because it was really funny. But in the BBC in the UK in the last kind of 24 hours have put out these 2 news stories. So on the left, there's one about robo taxis, so there's obviously interest in this in the UK right now. And then I guess I'm going to go home tomorrow to snow, which is really unexpected at this time of year. And so it's thinking about whether robo taxis, there's obviously some interest in the UK, but how will they work on snowy, icy roads? And there's tram tracks in Manchester, so I'm not sure how that's going to work. But, yeah, that's the news that you needed to be aware of in the last 24 hours. So final slide, really just to kind of echo myself and saying kind of many thanks, Peggy, for kind of hosting me, and Anne, sadly can't be here today, but who I may be online, for the invitation to visit, and to all those who provided support to make the visit happen. It really is appreciated, and so thank you. So it's been really, really fruitful, and I'm really pleased to have been able to make this trip down. So thanks also to all the people that I've worked with day to day. If you have any questions, comments, thoughts for collaborative kind of working, then please do get in touch. My email address is there, and do just reach out at any time. Thank you.
Great. If there's any questions, go ahead and ask people on Zoom. If you have questions, please put stuff in the chat. We're happy to facilitate. And I'd like to echo Rachel's thanks to all the operational folks who made this happen. Thank you so much for making her visit successful. It's great. So questions from the room.
I can start off. So of people that develop multimorbidity, maybe, splitting up between men and women, which condition typically happens first?
Yeah, good question. And I don't think we know, because that's what people are trying to establish now, because people have typically worked with health record data. We're dealing with people who've already reached the point of having multimorbidity as that starting point. So the argument starting with those data sets is because you have the granularity of data on conditions which you don't have in the cohorts. But my ambition is to then take the learning from the kind of granular data and the analyses of the electronic health records, take it back into the cohort studies where we have less well characterized conditions, but we still have data on health status, and do exactly some of those analyses that you're talking about there. So yeah, I think that's where it's headed, but we've not got there yet. There's been so much methodological work ongoing to grapple with how you characterize it and what the best way of meaningfully looking at it is. But yeah, good question.
Yeah, I have a question around life course epidemiology and lifestyle factors that often sort of are thought of like simultaneously. I think one in particular is life course epidemiology around exercise. So we always hear, well, nothing works for aging except maybe exercise and diet, and everyone should eat well and exercise. And there are all these longitudinal observational studies that show those who exercise more live longer. But of course, they didn't get diseases, so they were still able to exercise. So how do you think about these like cyclical, like confounding influences on factors? I mean, yeah, my personal view is that the effects of exercise are probably way overstated because of the confounding effects that people who exercise are healthy, not that they're healthy because they exercise. So what are your thoughts on that? And am I wrong?
No, I don't think so. I think I actually have a slide from another talk where I have it as a cycle, because especially as people get older, I don't know what you can infer from who's active and who's not, because that in itself is a marker of how well the people are aging rather than being the influence. So no, I would totally agree. and I guess thinking of the conversation I had with Brian yesterday, it's that challenge of, as an epidemiologist, how does one move away from just stating the really obvious, like eat well, exercise more, and you'll be okay. I mean, we do need to really be better at not just putting out those studies that say the obvious. And I guess that's part of what I grapple with day to day, is how do we do things on a bit more meaningful. But yeah, I think
I usually tell people to exercise, but also don't let anything happen to them that means that they can't exercise,
yeah.
which is the piece is even less satisfying, right? Because you really can't control it.
Everyone else probably knows the answer to this question in the room, but does race and ethnicity play a role in this?
For
comorbidities?
Yes, so it's less well kind of characterized. So there's a literature emerging on intersectionality. So a lot of the work on inequalities and multimorbidity is focused on socioeconomic inequalities. And so one of the kind of arguments I'll be making a presentation next week is around the need to think more carefully about kind of the intersection of age, sex, gender, and ethnicity. And the work that's come out in the UK, at least, on ethnicity is really quite kind of inconsistent. I think partly because ethnicity is so poorly coded in health records, and where there's missing data, it's usually not random, it's usually people from minoritized ethnic groups whose data are missing. So yeah, I think there's much more to say there.
I coming from Australia, I think the US documents ethnicity very well. It's asked in every single survey, it's asked in every single, and yeah.
But the challenge there is, I think, in the US, correct me if I'm wrong, I'm speaking to the room, but is that the relationships between race and kind of socioeconomic, other socioeconomic factors are so much more strongly correlated that it's quite hard to disentangle those in a way that I think that the associations aren't so strong in the UK, at least. So of course there is that, and that's one reason to look at intersectionality, but it's not so closely aligned as it is.
One after you.
Go ahead.
Oh, also that's a sign-in sheet that in front of you that needs to be passed.
Yes, thanks. I think it may have gone around. I'll pass it.
Oh, did it make a loop when it gets?
Go ahead and ask your question.
Oh.
Last.
I don't have as much experience with life course epi, but in the past, I studied a lot on epigenetics and the effects of like the developmental origins of certain diseases, including metabolic. And so one of the arguments is that our health is decided for us before we're even born. And one of the prime examples that you may be very familiar with is the Dutch hunger effects on metabolic health. And so I guess my question for you is, like, when you looked at the cohort differences, like the birth cohort differences, was there any attempt to look at what drove those differences? I mean, of course, there wasn't like famine probably that separated the birth cohorts, but is there an attempt to understand why different birth cohorts could have such a shift?
Yeah, so in that kind of Gription analysis, yeah, so we did interrogate that, and so most of the difference appeared to be due to education and height, and which speaks to a nutrition, early life nutrition story. So for us, it was an indication that there is something here from a life course perspective, and we do need to think early in life. Yeah, we've also done some analyses where we looked at comparing. There's lots of interest before more recent kind of news events in looking at kind of Norwegian versus Russian data and trying to interrogate there, because you see stark differences in kind of people from Russia in this specific birth cohort are much weaker than those people from an equivalent birth cohort in Norway. Lots of interest in both countries in trying to interrogate that, and it again speaks to this early life, these kind of early life influences.
And then I guess the follow-up question is, can you pass multimorbidity on? Like, if, for example, someone has heavy burden, do we expect their children to follow a similar course where they pick up either sarcopenia or multimorbidity burden?
Good question, to which I don't think I know the answer, but I think working with someone out of Edinburgh who's really interested in just those things and looking at the intergenerational relationships between, using some really amazing data out of the Welsh health records. So doesn't directly answer your question, but there's definitely thought towards kind of household risk. Yeah, great questions where I think there's a lot still to answer.
Very fun research.
Yeah, I'm sort of wondering about the distinction between accelerated age-related decline versus like developmental sort of variations? I mean, for like, are the people with low grip strength at age 43, are those people that had sort of normative grip strength at age 20 that then declined really quickly, or maybe they didn't develop, normative grip strength in the first place? And I guess my question is that a distinction that you think is relevant, or are there some conditions where that's relevant, or
So I think it probably is relevant. So I guess the point in trying to show that is that quite often when we're focusing on kind of older people, we assume that everything we're seeing and the variation we observe is due to the decline, and it's almost just making that point that there are other factors earlier in life that may have influenced the point they have achieved at one point in time. And then in terms of does that matter, I don't think we know that because we don't have enough studies where we can distinguish, because most of them, even where we've managed to collect these things early in life, slightly early in life, we haven't probably caught them at peak. So studies like ALSPAC out of the UK are now measuring grip strength with 30-year-olds. So we might be able to answer that in the future, but at the moment we don't have that. And I guess so we don't therefore understand whether the fact that you could have two people who are both weak and have the same grip strength at age 65, what the implications are of the fact they could have followed very different life course pathways to achieve that. But I would expect that they may be different, but I don't know. I'd be interested to know what Peggy thinks. But yeah, I think they probably are. And it also has important implications for potential mitigations that you might want to take early in life and interventions across life. So again, so much is unanswered, and is it probably the most important question to be asking? Probably not. There's other things we need to be doing here and now with people who are already experiencing this thing. But yeah, just highlighting the fact that not everyone has reached the same point, like the same need.
Yeah, and it depends on the metric. Like for osteoporosis, it's probably your current bone density, which is a proxy for your current bone strength. That's the biggest risk. It doesn't really matter how you got there. It's how osteoporosis is defined. It may make a little bit of difference in terms of your bone strength of how quickly you lost the bone, like what compartment of the bone it's lost from. But that it may not matter. There are other cases where the rate of decline may be important, but how will you actually interrogate that information into a clinical setting when you have 20 seconds to interact with your patient? So usually the data that we've looked at, does it change, or the measure where you end up? The usual answer is mostly the measure where you end up, and a little bit of information about change that is on the margin. Okay, they're not going to be necessarily true for everything. Probably dimension and cognitive change may be different, right? Because if you have lower education, you're never going to get a perfect score on the MOCA potentially. And rate of change there may be more important, but it's a really tricky thing to think about change and what's available and selection bias and all those other things that goes into this sorts of calculation. That's why it's a good thing for epidemiologists to study, because it's complicated and requires a lot of thought about bias studies.
Just to follow up on that, just to clarify. So when you say it's important, is it for the prediction of osteoporosis?
For prediction of fracture risk, that's what I mean. Is like the biggest risk for fracture is your BMD today. Yeah. And what your BMD was a year ago and how it's changed since then may provide marginal information, but the two most important things are your current BMD and how old you are. That explains such a huge variation in the risk of fracture, that anything else, just because the current measure and how old you are so important, that there's just very little space left in the variation for things like change to be important.
Yeah. So going back to your question, which I think is important, is like, what should I be looking for? Like, do I need to interrogate further back in time on like how they arrived at the measure that they have? I don't know if people agree with this, but I'm thinking if the goal is for prediction, the time that you have right now is what you want. But if you're trying to intervene, which is I'm thinking from a translational standpoint, then you kind of need to know how they got there, because otherwise you wouldn't know what to change. It could be the peak bone mineral, or it could be the loss rate.
Yeah, arresting a decline versus like improving the peak that they've ever been at, or it may look really different.
And that might reflect the genetic effect versus non-genetic lifestyle effects.
And that's also a case, osteoporosis, where it's measured relative to sort of young normal, right? I mean, it's measured
Yeah, that's
relative
an
to.
artifact though of the different technologies to measure bone density and to standardize across different machines than it is something that's like particular to bone health. So I wouldn't take that as that was a convenience operational thing than a biological factor.
Mhm. But one of the advantages of the BMD case is that there's a clear mechanistic link between BMD and fracture.
Yeah,
Whereas I think in most other conditions, like with sarcopenia, there's a much less mechanistic understanding of how that might relate to age-related diseases.
Yeah, I understand. The disease, the outcome is less directly tied to the condition.
Rachel, I was really inspired by your talk, and it makes me think about the two gaps that, there's the gap between your work and then the implementation of the public health side, and then there's also the gap between your work and on the other end of the spectrum, what an experimental laboratory-based scientist has. And I wonder where you think, what would be the most impactful to you in being able to bridge those gaps? If you could ask the experimental scientist for something, what would you ask for to help? And on the other side, what do you think is the most fruitful way we can direct those public health initiatives?
Yeah, good questions, which the challenge with the public, if I can take the last one, having worked in government for a while, there's no linear process to changing policy, and obviously it's kind of dependent. Evidence isn't always used in the most appropriate way. So I think I'm kind of coming down on the side of getting involved in those sorts of things where there's an opportunity through advocacy to kind of highlight this. That is where I think we do need to describe the problem and carry on describing the problem and do it well and kind of in an impactful way. So this supports saying going down to Parliament and presenting that to members of Parliament and saying, look, this is the situation. So more of that type of work. And it's the most basic of epidemiology to do that descriptive statistics and really helpful. So there's that side of things. And then thinking about the mechanistic side, I'm really not sure. I'm still grappling with that quite a lot at the moment, but I see that I work in a group where I have the privilege of working with people who have that expertise, and it is about relationship building more than it is about specific ask at the moment, but just being open to working with people who approach things in different ways, and even just recognizing that you do have different languages and you need to work on some common language. Yeah.
I feel like in this conversation, there's experimental data about exercise on rodents and how impactful it is, or about fetal exposure to obesity or something else. And how do we take those things from the lab and connect them with this kind of stuff? And is it going to be through looking at molecular markers from biopsies or whatever? But how do we connect? That would be useful.
Yeah.
Great. Thank you very much, Rachel, for your really great talk. We appreciate it. And we have a sign-in sheet. If you haven't done it, please write your name on the sign-in sheet. There's one going around. There's a list here. Please do that before you leave. It's important for the grant that fund these sort of talks. So thank you very much. All right, thank you, Rachel.